Thank you, Baron. Thank you, Mr. Chairman, inviting me again to give the talk about the highlights of last year. Here my possible conflicts of interest. My topic is coronary artery disease with emphasis on interventional cardiology. Well, the question is what happened after the last ESC in Amsterdam? Which major studies at big congresses have been shown? And for me, privately, I put always a note on the studies. Did these studies really change what I'm doing every day? Yes or no? So let's start with the congresses. Of course, after ESC, there was the TCT, the AHA, ACC, and EuroPCR. So let's start with the presentations of the TCT, which is the major interventional world congress, which was in October last year. Many drug-eluting stents, of course, have been presented. Here, the Dutch peer study from the Netherlands. And what they did is they were comparing two drug-eluting stents, the Resolute Integrity and the Promise Element stent. And the question was, were they similar or were there differences? It was an all-comer studies. This is very important. Randomized all-comer studies. As you can see here, 26% were bifurcation lesions, over 60% small vessels. So this is a really complicated everyday PCI study. Interestingly, there was no significant differences between both stents, and regarding stent thrombosis, both were below 1% with minimal differences, but this is background noise. So more or less, both stents are equivocal. And the low stent thrombosis rate may have been possibly related to the 1-year dual antiplatelet therapy. This is interesting because the European guidelines for 10 years now recommend 6 months dual antiplatelet therapy, but almost the majority of patients got 12 months. So there's some kind of uncertainty how long the dual antiplatelet therapy should persist. The scientific value of both studies was very high. The evidence-based medicine score, the maximum score is 10 points, was 9 points. So this is a very important scientific study. But the question remains, did Dutch peers really change my daily practice? Yes or no? And the answer is no. Why? Because so-called third generation drug-eluting stents are anyway the standard in our practice. So it's nice to have the study, but it doesn't change my life. Another study which was presented, a randomized trial, of course I speak a little bit from Prodomo because I was one of the co-investigators of this trial, was comparing the Promise element to the Xience Prime. Interestingly, the polymer is the same, the drug is the same, everolimus, but the only difference is the stent design. So this is the first study testing if different stent designs of the scaffold, so to speak, have an influence. And patients were randomized here, and more or less there was no significant difference, with some little differences trend, but it was overlapping, so more or less both stents are equivalent. So did Platinum Plus change my daily practice? And the answer is no. Why? Because we're using these stents anyway almost every day. So again, it's nice to have, but it doesn't change my life. The next drug-eluting stent trial was the sought-out 4 trial from Denmark. And here, interestingly, this is one of the first trials comparing different polymers, different coatings. One stent with sotorolimus had a durable, permanent coating, and the other stent had a biodegradable coating. And the question is biodegradable coating better than durable coating? And as you can see from the results, cardiac death, myocardial infarction, it's all the same. Target vessel revascularization, no difference at all. High scientific value with an evidence-based medicine score of 9, so very important data. And the question again, did sought-out 6 change my daily practice? The answer is no. Why? Because metallic drug-eluting stents with biodegradable coating, they still need to show they are clinically superior to the durable coatings. And as far as I remember, these studies have not been presented yet. So why should I change my daily practice if there is no advantage? The next study presented was RIPS-5, comparing drug-eluting balloon to a drug-eluting stent for in-stent restenosis in bare metal stents. Patients were randomized, low number of patients, less than 100 in both groups, but still important study. And as you can see, the outcome, the clinical outcome is the same. So this shows that you do not need to have to implant another stent. You can work very safely with a drug-eluting balloon tested here. And the question is, did RIPS5 change my daily practice? And the answer is no. Why? Because we are using anyway drug-eluting balloons as first-line therapy for in-stent restenosis. So another study comparing surgery with PCI was the hybrid trial. And what they did, they randomized 1-to-1. Hybrid revascularization means patient got both. They got bypass surgery, lima-rima, plus PCI with a drug-eluting stent, and the other group got only surgery. And there was some exclusion criteria: low ejection fraction, left main stem stenosis. Of course, left main stem stenosis is the domain of the surgeons, more or less. And interestingly, only 6% of patients had to switch. So the protocol could be followed in most of the patients. What are the results? More or less, both approaches are more or less clinically identical. So if you go to the subgroup analyses of the major events, there was no significant difference between both treatments. So the question is, did hybrid change my daily practice? And I think yes, indeed, it changed a little bit our practice. We are talking more again to our surgeons, and we have more patients with the lima-rima approach. And if instead of putting a vein graft and cutting off the legs, we do hybrid procedures with PCI. So I think that was an important study. Another study shown was the Euromax trial comparing balverudin to unfractured heparin or low molecular weight heparin, and patients were randomized to either group with a very surprising result, because major bleeding or death was higher here in the heparin group with balverudin compared, but even here a difference. Actually, there's a significant reduction with balverudin. So you would say, okay, that is great news, but, and here comes the but, we have a big problem because stent thrombosis was significantly higher in the group with balverudin. And again, this was already a little the same sign with the Horizons trial before. So did Euromax change my daily practice? And this is a very difficult question, because there are pros with a reduced bleeding rate compared to heparin and cons with increased stent thrombosis. So we'll come back to this topic with another study soon. Then the AHA in Dallas. I have only one study from the American Heart Association. The AHA is not so interventionally Congress. The STREAM study comparing thrombolysis with primary PCI again was presented here because the thrombolysis was done in the most best perfect way. As you can see here, symptom onset to first medical contact about 1 hour in the thrombolysis group, and the same in the PCI group. The time difference to randomization was about the same, 29 minutes here, 31 minutes here. And then, of course, tenecteplase was injected rapidly within 9 minutes, whereas the time to PCI took about 86 minutes. So this was a very good study comparing both methods. What are the results? No significant difference, maybe a little trend better for primary PCI, but overall mortality, no difference with thrombolysis versus PCI. Cardiac mortality, identical, and here the primary combined the same. But, and here comes the but, stroke. Again, even with the best drug and even with the best available protocol, there was a significant, highly significant increase in strokes with thrombolysis. So thrombolysis should really be done only if PCI is not available within 60 or 90 minutes. Did STREAM change my daily practice? And the answer is no, because in the Munich area at least, primary PCI is the treatment of choice. And thrombolysis may be reserved only for regions with no or low cath lab densities. So let's come to the ACC. Heat PCI was a very controversial study. What they really looked at is comparing again balverudin to heparin, but as you can see in these previous studies, there was a higher usage of GPI, glycoprotein inhibitor, in the heparin group. So the British said, this is not fair, we have to make a study where both groups have the same frequency of GPI use. As you can see here, this was achieved in this study. So this is the first study where both groups had the same GPI proportion. And interesting result, the first MACE event was lower with heparin than with bilirubin. This was really very surprising and also based on stent thrombosis. So this is the third study showing that bilirubin has a higher stent thrombosis rate as compared to heparin if you do not really use GP3A inhibitors. So did heat primary PCI change my daily practice? And I think yes, it changed the private practice because the advantage of bilirubin over unfractured heparin alone was questioned. So this is something which has to be investigated in the next years. Another study presented at the meeting was ZEUS, and what they did, they compared two drug-eluting stents. You may say, oh, not again another drug-eluting stent study, it's boring. But in this, it was for the first time that in patients with high risk of stent thrombosis, it was allowed to have a short 30-day dual antiplatelet therapy. This is a complicated slide, but look at here. In patients with high bleeding risk, dual antiplatelet therapy for only 30 days with drug-eluting stents was allowed. This is a little bit complicated slide too, but as you can see here in this slide, actually about 10% of the patients got dual antiplatelet therapy for 30 days. And despite this, the drug-eluting stent was better than the bare metal stent with major events, and still the drug-eluting stent was better than the bare metal stent with myocardial infarction, and the same is true for stent thrombosis. Highly scientific value with a evidence-based medicine score of 9. And did ZEUS change my daily practice? So you might think yes, but still the answer is no. But why? Why do I say no? Because it reassured what we are anyway already doing. We are giving to several patients only 1 month of dual antiplatelet therapy in patients with high risk of bleeding after implanting the Resolute stent. So you would say, why the Resolute stent? And here's the paper we have published recently in the European Heart Study, about 5,000 patients, where we have seen this here, that the risk of interrupting dual antiplatelet therapy or the risk of stent thrombosis is the highest in the first 30 days. But then the curve does not come down like this. It's an abrupt change. So in many patients, it is justified to give only 30 days of dual antiplatelet therapy, at least for the stent investigated here. And last but not least, the EuroPCR in Paris in May. There was the Century 2 trial, another randomized trial comparing two different drug-eluting stents, the Science as a reference and the Ultimaster, a totally new stent with a reabsorbed polymer. Only within 3 or 4 months, the polymer is gone. The polymer of the coating, not the polymer, not the stent itself. Target lesion failure was the same for both studies here. And again, very low stent thrombosis rate, below 1% for both stents. So did this study change my daily practice? No, it did not change. Why? Because metallic drug-eluting stents with absorbable coating have not yet shown to be superior. So why should I pay more money for a new stent which has not shown to be superior? If a company wants more money, they have to show that it really has advantages. So this is the last study. Of course, what's going on with the fully absorbable stents? Some people call it scaffolds, but they are stents. And of course, as you know, the Absorb is the first fully absorbable stent or scaffold. So in May this year, the first 800 patients were presented from all over the world here. So it's a really worldwide registry. And these numbers were presented, at least for the first 30 days, with 0% mortality, interesting, but a stent thrombosis rate for 0.3%. So it was not 0%, it was 0.3. But of course, 30 days is really not enough. And this is somehow in contradiction to another paper, and this is the last paper I show you now, which was just recently published in the Eurointervention Journal of another European registry here. And as you can see here, this was a little bit surprising. In 6 months, 180 days, there was a cumulative stent thrombosis rate of 2%, so much higher than the traditional old drug-eluting stents. And the most of the stent thrombosis rate was here in the first 30 days. This was really surprising. And what the authors have written is that although this stent is approved in Europe since 2011, so we have it now for 3 years, And many centers are increasingly using them for a variety of clinical and angiographic presentations, despite the paucity of compelling comparative data. So what we really need is now finally a randomized trial. We're using these from completely absorbable stents now for 3 years, and we still do not have a single randomized trial. So I hope that next year in London at the ESC, we'll have more data on randomized trials regarding the completely absorbable stents. Thank you.